Have you ever felt that, frustrating tightness in your chest, or maybe struggled to catch your breath after just a short walk and you're left wondering, what's actually going on with my lungs?
Yeah, those experiences are incredibly common, unfortunately.
Right. But what if we told you that two of the most prevalent lung conditions, which often seem really similar, are actually fundamentally different, like in ways that totally change how doctors treat them?
hmm
How do we tell them apart? And maybe more importantly, why does that difference matter so much for your health?
That's the crucial question.
So today we're taking a deep dive into chronic obstructive pulmonary disease, COPD, you probably know it as, and asthma.
Two big ones.
Exactly. Our mission here is to sort of cut through the confusion. We want to unpack the core differences in how they develop, how they're diagnosed, and importantly, the specific tailored treatments for each.
And we've looked at some really solid expert sources for this.
We have. We want to bring you a clear, comprehensive understanding that hopefully will really stick with you.
It's actually fascinating how these two conditions, I mean, they both affect your breathing, obviously, but they hide such different stories inside the body.
Right.
So we're going to try and pull out those crucial nuggets of knowledge, the things that won't just inform you, but actually empower you with a much deeper perspective on lung health. And especially why getting that diagnosis right is just absolutely critical.
Okay, let's get into it then, starting with COPD. Now, the Global Initiative for Chronic Obstructive Lung Disease, GOLD, for short, they define it as common, preventable, and treatable, which is good news.
Definitely. Preventable and treatable are keywords there.
But here's the really crucial point for our discussion. It involves persistent breathing problems, and this is key, irreversible airflow limitation.
That word irreversible is so important.
Why is that? What does it mean in practical terms?
It means the limitation, the difficulty getting air out, is due to long-term damage. Damage to the airways themselves or the tiny air sacs, the alveoli. And it's usually caused by significant exposure to, harmful stuff, particles, gases. Individual factors play a role too, but the damage itself, it doesn't just go away. It's a permanent change.
Permanent change. Okay. And what causes that damage typically?
Well, the major culprit by far is long-term exposure to tobacco smoke. No surprise there.
Right.
It's definitely not the only one. We also see significant risk from things like occupational dusts, chemicals, think miners, construction workers.
Okay.
General air pollution is a factor too.
Yeah.
Even certain past lung infections like TB can contribute.
Mm.
And then there's a small percentage of cases linked to genetic abnormalities. Makes some people more vulnerable.
Got it. So COPD isn't just one single thing then. You mentioned it shows up in different ways.
Exactly. It often presents in, well, doctors call them phenotypes.
Yeah.
Two main ones, although lots of people have a mix.
Okay, what are they?
First, there's chronic bronchitis. You can kind of think of this as the constant cougher type.
Oh, okay.
It's defined by having a persistent, productive cough, meaning you're coughing up mucus for at least 3 months of the year for 2 years straight.
Wow, that's specific.
It is. Then there's emphysema. This is quite different. It's really about the destruction of the actual walls of those tiny air sacs, the alveoli.
So not the tubes, but the little balloons at the end?
Precisely. This leads to abnormally enlarged air spaces in the lungs. And importantly, it happens without a lot of obvious scarring or fibrosis, initially at least.
And why does it matter to know which type is more dominant?
Well, briefly, it helps us understand where the main damage is happening. Is it more in the bronchial tubes, affecting mucus and airflow that way? Or is it more in the alveoli, affecting gas exchange and lung elasticity? It guides how we think about the specific problems.
Okay, this is where it gets really interesting for me, understanding how that damage actually happens in COPD. You mentioned irritants.
Right. So imagine your lungs are constantly exposed to these irritants, day in, day out, like a low-level attack.
Like smoking or pollution.
Exactly. This kicks off a continuous inflammatory response. Your body's immune system sends in the troops, neutrophils, macrophages, lymphocytes, trying to fight off what it sees as a threat.
But it doesn't stop.
That's the problem. Over time, this chronic, nonstop inflammation, plus something called oxidative stress, and just the sheer cellular damage, it leads to progressive, permanent changes in the lung tissue. Things get scarred, narrowed, destroyed.
Let's dive into that a bit more. How does it work in chronic bronchitis specifically?
Okay, so with chronic bronchitis, those inhaled irritants directly cause inflammation in the airways, right? The bronchial tubes. This makes the linings swell up and immune cells flood into the bronchial walls.
Okay.
Now, this inflammation causes the mucus glands and the cells that produce mucus goblet cells to get bigger and multiply. So you get way more mucus than normal, and it's often thicker.
Hence the productive cough.
Exactly. Plus, the smooth muscle around the airways thickens, and there's some fibrosis, some scarring. All this narrows the airways.
Makes it harder for air to get through.
Right. And another big problem, the cilia, those tiny hair-like things that normally sweep mucus out of your lungs, they get damaged. They don't work as well.
So the mucus just sits there.
Pretty much. It impairs clearance, compromises your lungs' defenses, makes infections more likely, and infections cause even more injury. It's a nasty cycle.
Wow.
So all that thick mucus and the narrowed, constricted airways obstruct airflow, especially when you breathe out. Air gets trapped in the deeper parts of your lungs. We call that hyperinflation.
Like the lungs are overinflated?
Kind of, yeah. Your chest might even expand over time, but the consequence is you're not moving air efficiently. Tidal volume, the amount you breathe in and out, normally decreases. This can lead to hypoventilation, too much CO2, building up hypercapnia, and a mismatch between ventilation and blood flow, what we call VQ mismatch, leading to low oxygen or hypoxemia.
Can you explain that VQ mismatch thing a bit more?
Sure. VQ stands for ventilation perfusion. Basically, it's the ratio of air reaching your alveoli, V, to the blood flow reaching the capillaries around them. Normally, it's around 0.8.
Okay.
In conditions like bronchitis or asthma, where airways are obstructed, you get poor ventilation in some areas. That's a low VQ. Air isn't getting to where the blood is. Conversely, if blood flow is reduced, like with a pulmonary embolism, you have a high VQ, air is there, but not enough blood.
So in bronchitis, it's a low VQ problem.
Primarily, yes. Low ventilation. And the body tries to compensate for this low oxygen and high CO2 by constricting blood vessels in those poorly ventilated lung areas, trying to shunt blood to better ventilated parts. But it's often not enough.
Okay, that makes sense. Now let's switch gears to emphysema. How is the damage mechanism different there? You said it wasn't mainly about mucus.
Right. Emphysema is fundamentally about the destruction of those alveolar walls. The partitions between the tiny air sacs break down.
So they become big, floppy spaces instead of lots of little ones.
Exactly. You get these abnormally enlarged air spaces.
Yeah.
They're just not effective for gas exchange. What seems to happen is the body's own immune response, triggered by the chronic irritation, kind of turns on the lung tissue itself.
An autoimmune component.
In a way, yes. Lymphocytes infiltrate, release toxic cytokines, and this leads to the breakdown of elastin, that crucial protein giving the air sacs their structure and elasticity, their bounce.
And without that bounce.
Well, first, the destruction creates these large, ineffective air pockets. We call them bullae within the lung, or blebs near the surface.
Yeah.
These don't participate properly in gas exchange, leading to VQ mismatch and hypoxemia, low oxygen.
Okay.
But the main source of airflow limitation in emphysema is the loss of that elastic recoil. Think of trying to blow air out of a crisp new balloon versus a saggy old one.
Much harder with the old one.
Exactly.
Yeah.
Without that natural springiness pushing air out, the airways tend to collapse during exhalation. This traps air, leads to hyperinflation, decreased tidal volumes, increased work of breathing, and again, you can end up with hypoventilation and hypercapnia, too much CO2.
So air trapping is a big issue in both, but for slightly different reasons.
Yes. In bronchitis, it's more about the mucus and airway narrowing. In emphysema, it's primarily the loss of elastic recoil causing airway collapse. Though persistent inflammation in emphysema can also lead to some bronchoconstriction, narrowing of the airways.
And you mentioned heart problems.
Right. When you destroy the alveolar walls, you also destroy the tiny blood vessels, the pulmonary capillaries within them. This increases resistance to blood flow through the lungs, leading to pulmonary hypertension, high blood pressure in the lung arteries. Over time, this puts a huge strain on the right side of the heart, which pumps blood to the lungs. Eventually, it can lead to right ventricular failure, which we call cor pulmonale.
Serious stuff.
Very serious. Also, interestingly, the presence of certain immune cells, like eosinophils, in emphysema can sometimes predict a lack of response to certain treatments.
And wasn't there a genetic form you mentioned briefly?
Yes. Primary emphysema. It's rare, only a small fraction of cases. It's caused by a genetic deficiency in a protein called alpha-1 antitrypsin.
What does that protein normally do?
It protects the lungs by inhibiting enzymes, like elastases, that can break down lung tissue. Without enough of it, these enzymes run wild, especially if you smoke, leading to early onset emphysema, often diagnosed before age 40, even in non-smokers. It can affect the liver too, causing fibrosis.
Okay, good to know. So let's shift to diagnosis. If someone is experiencing symptoms, what usually brings them to the doctor for potential COPD?
The classic symptoms are persistent shortness of breath, especially with activity, a chronic cough that just hangs around, maybe with mucus production. And often, recurrent lower respiratory infections, lots of chest colds or bronchitis episodes.
And once they're at the doctor's, how is it assessed?
Well, besides the history and physical exam, doctors often use questionnaires to gauge the impact on the patient's life. Things like the CATES assessment COPD assessment test, or the MMRC scale, which focuses specifically on breathlessness during various activities.
But those aren't the final diagnosis, right?
No, they help understand severity and impact. The official gold standard diagnosis is made with spirometry.
All right, you mentioned that earlier. Can you walk us through what that test is actually like?
Sure. You'll sit down, they'll put a clip on your nose, and you'll breathe into a mouthpiece connected to the spirometer machine.
Okay.
The technician will coach you. You'll take the deepest breath you possibly can, then blast it all out as hard and as fast as you can, keeping going for at least 6 seconds. Really empty those lungs.
Sounds like hard work.
It takes effort. Then right after that full exhale, you immediately take another deep, forceful breath back in. You'll usually do this maneuver 3 times to make sure the results are consistent.
And what are they measuring?
2 key things primarily. First, FVC, forced vital capacity. That's the maximum total amount of air you can forcefully exhale after taking your deepest breath.
Okay, the total volume.
Right. Second, FEV1, forced expiratory volume in 1 second. That's how much of that total air you can blast out in the very first second of exhaling.
Ah, the speed part.
Exactly. And the crucial number for COPD diagnosis is the ratio of these two, FEV1 divided by FEC. Normally, you can get most of your air out, like 80% or more in that first second.
Makes sense.
But in COPD, because of the airflow limitation, that ratio is lower. The diagnostic criterion is an FE1-FEC ratio of less than 0.7 or 70%. And importantly, this is measured after giving a bronchodilator medication to open up the airways as much as possible. If the limitation persists even then, that strongly suggests the irreversible obstruction of COPD.
Okay, that distinction after the bronchodilator seems really important.
It is. It helps differentiate COPD from conditions like asthma, where the obstruction is typically reversible. We'll come back to that.
Got it. So once COPD is diagnosed via spirometry, how is it classified?
Doctors use the GOLD classification system. It looks at 2 things, severity and risk.
How is severity measured?
Severity is based purely on that FEV1 measurement from spirometry, compared to predicted normal values. It ranges from GOLD D1, which is mild, up to GOLD D4, which is very severe.
And risk?
Risk classification is a bit more complex now. It looks at a combination of how many exacerbations those flare-ups you've had in the past year, especially ones needing hospitalization, and your symptom burden, using those CAT or MMRC scores we mentioned.
Okay.
So basically, if you have frequent exacerbations or were hospitalized for one, you fall into Group E that signifies higher risk and usually needs more intensive treatment. If you have fewer exacerbations but still significant symptoms affecting daily life, you might be Group B. And if you have few exacerbations and fewer symptoms, you're Group A. There used to be C and D groups, but the guidelines simplified it a bit recently.
So Group E is the highest risk category now.
Yes, essentially. It flags patients needing more comprehensive management to prevent future flare-ups.
Okay, that makes sense.
Yeah.
So let's talk treatment. If someone has COPD, what can actually be done? Let's start with the non-medication stuff, the non-pharmacologic side.
Absolutely critical. These are the foundation. First up, vaccinations. Hugely important to protect vulnerable lungs. We're talking annual flu shots, RSV vaccination if you're over 60 with a chronic lung condition, definitely COVID-19 vaccines and boosters, Tdap if you didn't get it as an adolescent, the zoster vaccine for shingles if you're 50 or older, and pneumonia vaccines, usually PCV15 or PCV20, followed by PPSV23 a year later.
That's a lot of shots, but sounds important.
It really is. Next, and this is non-negotiable if relevant, smoking cessation. It is the single most effective thing a smoker with COPD can do to slow down the disease progression.
What helps with quitting?
We have good medications now. Varenicline, which is Chantix, or bupropion, Zyban. Often the best approach is combining methods like using a nicotine patch for steady baseline control, plus nicotine gum or lozenges for sudden cravings. Counseling and support groups are vital too.
Okay. What else beyond smoking and vaccines?
Staying active is key. Gentle exercise as tolerated. Diligently managing any other health problems, comorbidities like heart disease or diabetes, because they often go hand in hand with COPD. Pulmonary rehabilitation programs are fantastic. They combine exercise training, education, and support to improve breathing, function, and quality of life. And finally, for those with low oxygen levels, oxygen therapy is essential.
So a really comprehensive approach even before medication?
Absolutely. You can't just rely on inhalers. Lifestyle is huge.
Okay, let's move to the medications, the pharmacologic side. You mentioned inhalers. There are different types, right?
Yes, several types, and how you use them matters. There are dry powder inhalers or DPIs. These deliver medicine as a fine powder. The key here is the patient needs to be able to inhale deeply and quickly to pull the powder into their lungs.
So you need good inspiratory effort.
Exactly. The steps are usually open the device, breathe out fully away from it, seal your lips around the mouthpiece, breathe in deeply and quickly, hold your breath for about 10 seconds, then breathe out slowly.
Okay. What else?
Then you have metered dose inhalers, or MDIs. These are the traditional puffer type. They deliver a short burst of aerosolized medicine. Coordination is key here.
I've heard people use spacers with those.
Yes, spacers are often recommended, especially for kids or older adults, or anyone who finds the coordination tricky. A spacer is a chamber that holds the medicine cloud briefly, so you can just breathe in normally from the chamber after puffing the inhaler into it. Makes it much easier to get the full dose.
How do you use an MDI without a spacer?
Remove the cap, shake it well, breathe out fully, put the mouthpiece in your mouth or just in front, start breathing in slowly and deeply, and while you're breathing in, press down on the canister to release the puff. Keep inhaling, hold for 10 seconds, then breathe out.
Got it. Any other types?
There are soft mist inhalers, or SMIs. These turn liquid medicine into a fine, slow-moving mist. They require less coordination than MDIs. You typically twist the base, open the cap, breathe out, seal your lips around the mouthpiece, avoiding the air vents. Press the button while inhaling slowly, and hold for 10 seconds.
Sounds easier.
It can be for some. And finally, nebulizers. These are small machines often used at home or in hospitals. They turn liquid medication into a continuous mist that you breathe in through a mouthpiece or mask over several minutes, maybe 5 to 15 minutes. No special coordination needed, just normal breathing.
Okay, so different options depending on the patient's ability and preference.
Exactly. Matching the device to the patient is important for ensuring they actually get the medication into their lungs where it's needed.
So now we know the devices. What medications go in them for COPD, according to those GOLD guidelines you mentioned?
Right. The guidelines base recommendations on those patient groups A, B, and E.
Okay.
For Group E, the highest risk group with frequent exacerbations, the standard starting point is a combination inhaler containing both a LABA, long-acting beta agonist, and a LAMA, long-acting muscarinic agent.
Two long-acting bronchodilators together.
Correct. They work in different ways to open the airways. Now, if a patient in Group E also has high levels of eosinophils in their blood, those immune cells we mentioned, suggesting more underlying inflammation than adding an ICS, inhaled corticosteroid, to the LABA/LAMA is recommended, so triple therapy.
What about the lower risk groups?
For Group A, low symptoms, low exacerbation risk, usually starting with just a single bronchodilator, either a LABA or a LAMA, is sufficient.
And Group B?
For Group B, more symptoms but still low exacerbation risk, the recommendation is generally to start with that LABA plus LAMA combination, similar to Group B, because symptoms are bothersome even if exacerbations aren't frequent.
So the LABA/LAMA combo is pretty central to COPD management now.
It really is the cornerstone for most symptomatic patients or those at higher risk of exacerbation.
Okay, let's break down those medication classes. What exactly do LABAs and LEMAs do?
Sure. LABA's long-acting beta agonists, things like salmeterol, formoterol, olodaterol, they work by stimulating specific receptors, beta-2 adrenergic receptors, in the smooth muscle of the airways. This causes the muscles to relax, leading to bronchodilation, opening up the airways. They usually start working within minutes to hours and last for 12 or even 24 hours.
Are there side effects?
Yes, potentially. Because they stimulate beta receptors, they can sometimes cause tachycardia or palpitations, nervousness, tremor, occasionally low potassium levels, headache, or muscle pain.
Okay. And LEMAs?
LEMA's long-acting muscarinic agents. Examples include tiotropium, mumeclidinium, aclidinium. These block the action of acetylcholine, a neurotransmitter, on N3 receptors in the lungs. Acetylcholine normally causes airway muscle contraction, so blocking it leads to relaxation and bronchodilation. They also last 12-24 hours.
Side effects for LEMAs?
They can cause anticholinergic side effects, things like dry mouth, maybe constipation, urinary retention, sometimes blurry vision, usually mild, but something to watch for.
And the ICS inhaled corticosteroids?
Right. Medications like fluticasone, budesonide, mometasone, their job is to reduce inflammation directly in the airways. They don't provide immediate bronchodilation like LABAs or LAMAs.
Are they used alone in COPD?
Generally not recommended as monotherapy in COPD, unlike in asthma. They're usually added to LABAs or LABA/LAMA combinations for specific patients, particularly those in Group E with high eosinophils or frequent exacerbations despite LABA/LAMA use.
Any important points about using ICS?
Yes, a couple of big ones. Regular use can slightly increase the risk of pneumonia in COPD patients, and it's really important to rinse your mouth thoroughly with water and spit it out after each use.
Why is that?
To prevent oral thrush or pharyngeal candidiasis, which is a yeast infection in the mouth and throat caused by the steroid depositing there, rinsing helps wash it away. Other potential side effects can include hoarseness, fatigue, headache, or musculoskeletal pain.
Okay. And you mentioned combination inhalers are common.
Very common now. We have many inhalers that combine a LABA and an ICS, like salmeterol fluticasone or the formoterol butanide. We also have Labana combinations, like vilanterol umeclidinium or olidaterol tiotropium, and even triple therapy inhalers that contain a LABA, a LAMA, and an ICS all in one device, like vilanterol umeclidinium fluticasone.
Makes it simpler for patients than using multiple inhalers.
Exactly. Better adherence is often a benefit.
Are there any other types of medications used?
Yes, couple more worth mentioning. There's a pill called roflumilast. It's a phosphodiesterase 4 inhibitor. It works differently to reduce inflammation systemically and can help reduce exacerbations, especially in patients with severe COPD, chronic bronchitis features, and a history of flare-ups.
Okay.
And in some specific cases, for patients who continue to have frequent exacerbations despite optimal inhaler therapy, long-term use of certain antibiotics like azithromycin or erythromycin, usually taken daily or 3 times a week, has been shown to reduce exacerbations over a year.
But wouldn't that lead to antibiotic resistance?
That's the major concern, absolutely. It's a trade-off. There are also potential side effects, like hearing changes with azithromycin, so it's reserved for specific situations after careful consideration.
Makes sense. What about follow-up? Do treatments ever get adjusted?
Definitely. Follow-up is key. If someone is stable, particularly if they were started on triple therapy and aren't having exacerbations, or if they develop side effects like recurrent pneumonia, doctors might consider de-escalating therapy, for example, stopping the ICS. It's about finding the minimum effective treatment.
Always reassessing. Okay. So what happens when things go wrong? Let's talk about those COPD exacerbations. What exactly is happening?
An exacerbation is basically an acute worsening of a patient's usual respiratory symptoms, more breathlessness, more cough, changes in sputum that's significant enough to require additional therapy.
What usually triggers them?
Most often, it's infections, viral or bacterial respiratory infections are the main culprits. But air pollution or other irritants can trigger them too. During an exacerbation, there's a significant increase in airway inflammation, mucus production, and gas trapping compared to the stable state.
What are the key signs and symptoms doctors look for?
The classic cardinal symptoms are increased dyspnea, shortness of breath, increased sputum volume, and increased sputum purulence, meaning the mucus becomes thicker and more colored, often yellow or green. Increased cough and wheeze are also common.
And how are these flare-ups treated acutely?
The immediate goals are to relieve symptoms and reduce inflammation. This usually involves increasing the use of short-acting bronchodilators like SABAs, short-acting beta agonists such as albuterol or levobuterol. These can be given via MDI, DPI, or often via nebulizer during an acute event, sometimes frequently at first.
Like rescue inhalers.
Exactly. They provide quick relief. Using a spacer with MDIs is often helpful here too. Side effects are similar to LABAs, but may be more pronounced with frequent use tachycardia, nervousness, tremor. Some now short-acting anticholinergics are added too.
What about inflammation?
Oral corticosteroids are crucial. A short course, typically prednisone 40 milligrams daily for about 5 days, is standard. They significantly reduce inflammation, shorten recovery time, improve lung function and oxygen levels, and reduce the risk of relapse or treatment failure.
Are antibiotics always needed?
Not always, but they are recommended if the patient has at least 2 of those 3 cardinal symptoms we mentioned: increased dyspnea, increased sputum volume, and increased sputum purulence, especially if increased purulence is one of them.
Why? What are they treating?
They target the most common bacteria known to trigger these exacerbations, like Haemophilus influenza, Moraxilla catarrhalis, and Streptococcus pneumonia. Common choices might be amoxicillin clavulanate, a macrolide like azithromycin, or a tetracycline. Sometimes stronger antibiotics are needed for higher-risk patients.
Anything else?
Supplemental oxygen is given if oxygen levels are low. And it's really important for doctors to do a differential diagnosis, make sure the breathing difficulty isn't actually due to something else, like a pulmonary embolism, heart failure, or pneumonia, which require different treatments.
Right. Good point. Okay, let's completely shift gears now and talk about asthma. You said it's a different beast, even though some symptoms overlap. How does it work fundamentally? Let's get into the asthma pathophysiology.
Okay, so asthma is fundamentally an inflammatory disorder of the airways, but the type of inflammation and the triggers are often quite different from COPD. It usually starts when the airway lining, the epithelium, is exposed to an antigen, something the immune system reacts to, like pollen, dust mites, pet dander, certain foods, or even viruses.
So more of an allergic or hypersensitivity reaction?
Often, yes,
Yeah.
especially in younger people. This exposure kicks off both innate and adaptive immune responses. Let's talk about the early asthmatic response first.
Uh,
The antigen is picked up by specialized immune cells called dendritic cells. They present it to T helper cells, which then differentiate into a specific type called Th2 cells. These Th2 cells are key orchestrators in asthma. They release a bunch of chemical messengers called cytokines, things like interleukin-4, IL-4, IL-5, IL-13, and IL-33.
What do those interleukins do?
They have specific jobs. IL-4 activates B lymphocytes, which are immune cells that produce antibodies. IL-5 activates eosinophils, another type of immune cell heavily involved in asthma, and increases airway hyperresponsiveness. IL-13 contributes to airway injury and remodeling. IL-33 helps Th2 cells mature and activates other inflammatory cells like mast cells and basophils.
Wow, a complex signaling cascade.
Very. So those B lymphocytes, activated by IL-4, start producing antigen-specific IgE antibodies. This IgE then binds to the surface of mast cells, which are stationed in the airways.
Like setting a trap.
Exactly. The next time that same antigen comes along, it binds to the IgE on the mast cells, cross-linking them. This triggers the mast cells to degranulate, basically, dump out a whole load of potent inflammatory mediators. Histamine, bradykinin, leukotrienes, prostaglandins, platelet activating factor, more interleukins,
Chemical explosion almost.
pretty much.
Right.
And the combined effect of all these mediators is rapid and dramatic. They cause vasodilation, blood vessels widen, increase capillary permeability, leading to fluid leakage and swelling or mucosal edema, intense contraction of the smooth muscle around the airways, bronchospasms, and increased mucus secretion. All of this narrows the airways, causing the classic asthma symptoms.
And it happens quickly.
Yes, this early response can happen within minutes of exposure. On top of that, the inflammation also triggers the parasympathetic nervous system to release acetylcholine, which binds to M3 receptors, just like we discussed with the LAMAs. But here it causes further bronchospasm and mucus secretion.
So multiple pathways leading to airway narrowing.
Correct, but it doesn't always stop there. There's often a late asthmatic response.
What happens then?
This typically occurs 4 to 8 hours after the initial exposure. More inflammatory cells, especially those eosinophils activated by IL-5, along with neutrophils and lymphocytes, migrate into the airways.
So a second wave of inflammation.
Exactly. They release more inflammatory mediators, prolonging the bronchospasm, edema, and mucus secretion, leading to sustained airflow obstruction. Leukotrienes in particular are known to cause prolonged smooth muscle contraction.
And those eosinophils.
They can be particularly damaging. They release toxic substances that directly injure the airway lining. This chronic injury, if asthma isn't well controlled, can lead to long-term structural changes in the airway wall. Things like thickening of the layer beneath the epithelium, subepithelial fibrosis, and enlargement of the smooth muscle hypertrophy. This is called airway remodeling.
So this is where asthma can become irreversible.
Precisely. While the hallmark of asthma is reversible obstruction, chronic, poorly controlled inflammation can lead to these remodeling changes, which may become permanent over time, making the asthma harder to treat and potentially leading to a fixed airflow limitation similar to COPD. That's why consistent treatment is so vital.
Got it. What are the other consequences of this obstruction?
Similar to COPD in some ways, the difficulty exhaling leads to air trapping and hyperinflation, increasing the work of breathing. Because the obstruction isn't uniform throughout the lungs, you get VQ mismatch and hypoxemia, low oxygen. Initially, the body often hyperventilates in response to lung receptors being stimulated, which can actually blow off too much CO2, leading to a low KCO2 and respiratory alkalosis, high blood pH.
So initially CO2 might be low.
Yes. But if the obstruction becomes severe and prolonged, air trapping worsens, ventilation becomes inadequate, and eventually CO2 levels start to rise, hypercapnia, leading to respiratory acidosis, low blood pH. This is a sign of impending respiratory failure.
A dangerous progression.
Very. Which brings us to the most severe form, status asthmaticus.
What defines that?
This is basically a severe asthma attack where the bronchospasms are so intense and persistent that they don't respond to the usual rescue treatments, like standard doses of bronchodilators. It leads to worsening hypoxemia, acidosis, and potentially that silent chest we mentioned earlier, where airflow is so poor you can't even hear wheezing anymore. It's a true medical emergency.
Okay, scary stuff. So, stepping back from the extreme, what are the typical signs and symptoms that suggest someone might have asthma?
Patients often describe a feeling of chest tightness or constriction. Expiratory wheezing, that whistling sound when breathing out, is classic. Shortness of breath, dyspnea, often episodic. A cough, which is frequently non-productive, dry, but can sometimes have mucus, especially after an attack. They might notice their expiration takes a long time. During an attack, you might see them using accessory muscles in their neck and shoulders to breathe, and they might have tachycardia, fast heart rate, and tachypnea, fast breathing. Sometimes a finding called pulsus paradoxus occurs, where blood pressure drops more than usual during inhalation.
And what might a doctor find on a physical exam?
They might see signs of hyperexpansion of the chest, observe that accessory muscle use, maybe the patient is sitting hunched forward. Wheezing might be audible even during normal breathing, or definitely during forced exhalation. Sometimes there are related findings suggesting an allergic tendency, like increased nasal discharge, swollen nasal lining, nasal polyps, or allergic skin conditions like eczema.
So, you gather the history, do the exam. How is asthma definitively diagnosed? You mentioned spirometry again, but with a key difference.
Yes, spirometry is again the key diagnostic tool. Just like with COPD, we measure FVC and FEV1 and calculate the FEV1-FVC ratio. Before giving a bronchodilator, in someone with asthma, you'd expect to see evidence of obstruction, that FEV1-FVC ratio being low, less than 70% in adults or maybe less than 85% in children. The threshold can vary slightly.
Okay, so far sounds like COPD.
Right. But here's the absolute crucial difference, the hallmark of asthma. After the patient inhales a short-acting bronchodilator like albuterol, you repeat the spirometry. If the FEV1 improves significantly, typically defined as an increase of 12% and at least 200 milliliters from the baseline value, that demonstrates reversibility of the airflow obstruction.
So the airways can open back up relatively easily with medication.
Exactly. That reversibility is what confirms the diagnosis of asthma and distinguishes it fundamentally from the largely irreversible obstruction seen in COPD.
That's a really clear distinction. So once asthma is diagnosed, what are the main goals of treatment?
The goals are really twofold: symptom management and risk reduction. We want to control symptoms so people can live normal, active lives without limitations from their asthma. And we want to reduce the risk of future problems, primarily asthma attacks or exacerbations, loss of lung function over time, and side effects from medications.
And are there non-pharmacologic strategies, like with COPD?
Yes, definitely. Vaccinations are important here too: flu, pneumonia, COVID, etc. Identifying and avoiding known triggers is huge for asthma, whether it's allergens, tobacco smoke, first or secondhand, strong odors, cold air, even exercise for some, although we encourage exercise with proper management. Maintaining an active lifestyle is actually beneficial for most people with asthma. Pulmonary rehab can sometimes be helpful for severe cases too.
Okay, now let's get into the medications for asthma. How is treatment typically approached?
Asthma treatment is usually guided by a stepwise approach, outlining guidelines like EPR4 from the NIH or the Global CHINE guidelines.
Stepwise, what does that mean?
It means treatment intensity is stepped up if asthma isn't controlled, and potentially stepped down if it's well controlled for a period. The goal is to find the lowest step, the minimum amount of medication, that maintains both good symptom control and low risk of exacerbations.
Makes sense. What are the core medications?
The absolute cornerstone of asthma treatment, especially for persistent asthma, is inhaled corticosteroids, ICS. Because inflammation is so central to asthma pathophysiology, ICS are vital for controlling that underlying inflammation on a daily basis.
So different from COPD, where they're used more selectively.
Exactly. In asthma, they are first line for most patients needing daily control. Then, depending on the severity and level of control, other medications are added. Long-acting beta agonists, ADAs, are often added to ICS if the ICS alone isn't enough. They should almost never be used alone in asthma, always combined with an ICS, often in the same inhaler device.
Mine alone.
Using LABA alone can manage symptoms but doesn't address the underlying inflammation. And studies showed it could potentially increase the risk of severe exacerbations or even death when used without an ICS. So Labacus combination inhalers are very common.
Okay. What about rescue medication?
Traditionally, short-acting beta agonists, SABAs, like albuterol, were the go-to rescue inhaler for quick relief of symptoms. However, guidelines are shifting.
How so?
There's growing recognition that relying solely on SABA for rescue doesn't address the inflammation driving the symptoms. So for many patients, particularly those using an ICS-LABA combination containing formoterol, which is a LABA that also has a fast onset, the recommendation is now to use that same ICS formoterol inhaler for both daily maintenance and as needed for rescue relief.
Ah, so the maintenance inhaler doubles as the rescue inhaler.
Yes, it's often called SMART therapy, single maintenance and reliever therapy. The idea is that every time you need rescue, you also get a dose of the anti-inflammatory ICS along with the fast-acting bronchodilator. This has been shown to reduce severe exacerbations compared to just using a SABA for rescue.
Interesting shift. But you mentioned something earlier about not using an ICS formoterol for rescue if the patient uses a different maintenance inhaler.
Right, that's an important safety point. If your regular maintenance inhaler is, say, an ICS-LABA combo that doesn't contain formoterol or just an ICS alone, then you should not use a separate ICS formoterol inhaler just for rescue. You typically use a SABA for rescue in that case. Using multiple different controller inhalers can get confusing and risky.
Got it. Keep it simple if possible. What about other medication classes for asthma?
There are several others used as add-on therapies. Leukotriene receptor antagonists, LTRAs, like montelukast singulair, are pills taken once daily.
How do they work?
They block the action of leukotrienes, those inflammatory mediators we talked about that cause airway swelling and muscle contraction. They can be helpful, especially for allergies and exercise-induced asthma, usually taken in the evening as symptoms can worsen at night.
Any downsides?
Headache is common, but the big one is the black box warning for potential neuropsychiatric events, mood changes, agitation, aggression, depression, sleep disturbances, even suicidal thoughts. It's really important for patients and doctors to be aware of this risk.
Definitely. What else?
There's a related drug, Xyluton, which is a 5-lipoxygenase inhibitor. It works higher up the pathway to block the formation of leukotrienes. It's less commonly used, partly due to dosing frequency and potential liver effects.
Okay. And the more advanced therapy?
Right, the monoclonal antibodies, often called biologics, these are injectable therapies reserved for severe, uncontrolled asthma, usually identified by specific inflammatory markers like high eosinophils or allergic profiles. They are highly targeted.
Can you give examples?
Omalizumab, Xolair, targets IgE, the antibody involved in allergic reactions. It stops IgE from binding to mast cells, preventing the release of those allergic mediators. It requires careful dosing based on weight and IgE levels, and also carries a black box warning for anaphylaxis, although rare.
Okay.
Then there are several that target the IL-5 pathway, which is crucial for eosinophils. Reslizumab and mepolizumab directly antagonize IL-5. Benralizumab binds to the IL-5 receptor on eosinophils, basically flagging them for destruction by other immune cells. These are very effective for severe eosinophilic asthma.
Targeting specific inflammatory cells.
Exactly. And another one, dupilumab, blocks the signaling of both IL-4 and IL-13, key cytokines involved in the Th2 inflammation pathway. So different biologics target different specific parts of the complex asthma inflammation. They are game changers for the right patients, but require specialist management.
Fascinating how targeted treatments have become. Any other classes?
One older class, sometimes still used, though less common now, is mast cell stabilizers, like cremolin. They work by preventing mast cells from releasing their inflammatory contents when exposed to triggers. Usually it needs frequent dosing and mainly used for prevention.
Okay, so a whole toolkit depending on severity and type of asthma. Now, how about managing asthma exacerbations? How does that differ from COPD flare-ups?
The principles are similar: relieve bronchospasm, reduce inflammation, but the specifics can differ. We often categorize asthma exacerbations as mild, moderate, or severe.
How are mild ones handled?
Mild exacerbations can often be managed at home if the patient has a clear written asthma action plan from their doctor telling them exactly what to do.
What does that usually involve?
Typically, increasing the use of their rescue inhaler, SABA or ICS formoterol, is appropriate. Sometimes adding a short burst of oral corticosteroids, like prednisone 40-50 milligrams per day for 5-7 days, can help quickly control the inflammation and prevent worsening. Some might use antihistamines if allergies are a trigger.
You mentioned things not to do for mild exacerbations.
Right. Some common misconceptions. Drinking lots of extra liquid doesn't really help thin mucus in the airways. And inhaling warm, moist air like steam isn't recommended and can sometimes irritate airways further. Stick to the prescribed plan.
Okay. What about more serious attacks?
Moderate to severe exacerbations usually require urgent medical attention, often in the emergency department or hospital.
What happens there?
Assessment includes monitoring oxygen levels, maybe lung function tests, PFTs if possible, sometimes arterial blood gases, ABGs, in severe cases. The goal is to keep oxygen saturation typically between 93–95%.
And treatment.
Aggressive bronchodilation is key. This often involves nebulized SABA, like albuterol, given frequently, maybe every 20–30 minutes initially, assessing the response after a few doses. In severe cases, ipratropium, a short-acting muscarinic antagonist, SAMA, is often added to the SABA nebulizer treatment to provide additional bronchodilation through a different mechanism.
So hitting it from two angles.
Exactly. And systemic corticosteroids, oral prednisone, or intravenous steroids like methylprednisolone are absolutely crucial for moderate to severe attacks to control the intense inflammation. They're started early.
Are there other options for very severe attacks?
Yes. If someone isn't responding well to standard therapy, intravenous magnesium sulfate can sometimes help relax airway's smooth muscle. In rare, life-threatening cases, Heliox, a mixture of helium and oxygen which is less dense than air, might be used to improve airflow.
You mentioned ipratropium, the SAMA. Tell me more about that one.
Right, ipratropium bromide. It blocks acetylcholine in the lungs, similar to LAMAs, but it's short-acting. Onset is maybe 15–30 minutes, duration 4 to 6 hours. It's primarily used in addition to SABAs during moderate to severe asthma exacerbations, not typically for routine asthma management. Side effects can include bronchitis, sinusitis, or anticholinergic effects like dry mouth.
Okay. And crucially, what should not be done during moderate to severe exacerbations?
Good question. Certain things are generally not recommended or can even be harmful. Methylxanthines, like theophylline, are rarely used now due to side effects and limited benefit over standard therapy. Antibiotics should only be used if there's clear evidence of a bacterial infection like pneumonia or bacterial sinusitis. They don't treat the asthma itself. Aggressive hydration isn't helpful. Routine checked physical therapy, CPT, isn't effective for asthma attacks. Mucolytics that thin mucuses generally aren't recommended. And importantly, sedation should be avoided if possible, as it can suppress the respiratory drive.
Lots of important do's and don'ts there.
Managing exacerbations effectively requires knowing what works and, just as importantly, what doesn't.
Okay, so what does this all mean for you listening? Today, we've really taken a deep dive into COPD and asthma, two conditions that, yes, affect breathing, but as we've seen, are just incredibly distinct in their fundamental nature. We've explored how COPD is typically about that long-term irreversible airflow limitation, often from chronic irritants causing permanent damage.
Right, that irreversible piece is key for COPD.
Whereas asthma usually involves airway inflammation that's reversible, triggered by these complex immune responses. Although, crucially, we learned it can become irreversible if it's not well managed over the long haul.
That potential for remodeling is why consistent asthma control is so vital.
Absolutely. And we highlighted how critical accurate diagnosis is, especially using spirometry to spot that hallmark reversibility in asthma, setting it apart from COPD.
Can't emphasize diagnosis enough.
And finally, we walk through the very tailored treatment approaches from those foundational vaccinations and lifestyle changes right through to highly specific medications, whether it's combination inhalers for COPD or targeted biologics for severe asthma. It really underscores that personalized medicine is essential here.
It really is. And what's truly insightful, I think, is realizing that even though both conditions make it hard to breathe, understanding their unique underlying mechanisms, the why behind the symptoms, fundamentally changes how we approach them clinically. This knowledge isn't just for doctors. It empowers individuals like you to better understand your own lung health, ask the right questions, and be an active partner in managing these conditions effectively. Getting the right diagnosis and the right treatment plan makes a world of difference.
So maybe a final thought to leave you with. What might these distinctions between two seemingly similar lung diseases tell us about the nature of chronic illness more broadly? And maybe how can applying this kind of deep dive approach, really seeking to understand complex information, empower us in other areas of our health or even our lives? Something to think about.